ourselves. That's helpful. Let's see, for some reason, I'm not getting a lot of us. Okay, so some of you know me. I'm Lisa Vigil Shadinger. I am founder and executive director of Ohio End of Life Options. My training is as a nurse. I came to this because for a period of time, as happens with some people, my mother and I, between the two of us, were healthcare proxy for I think 4 different people who died between the ages of 73 and 104. And, you know, each person was unique, just as we all are, with regard to their healthcare issues, you know, their financial well-being, lots and just their living scenarios, lots and lots of different things came into play, of course, as their life drew to an end. And so I really appreciate all that we learned showed us how much we have to talk about and plan ahead for ourselves and for our loved ones. So just a reminder, we have a series of 3 talks. The next one, it's each next Tuesday, and then the Tuesday after that, starting at 7, hopefully for about an hour. And the next 2, Monica Garrick is an ethicist who works at Metro Health. So she's got a lot of experience with this, and I'm really looking forward to her discussing the real life scenarios and nuts and bolts of advanced directives. And then Molly McMahon Graziano is our director of education and outreach, and she's fantastic at giving you sort of online and different ways to pull all of this together and have access to these things. And I want to make sure to acknowledge that a grant from the S. Livingston Mather Charitable Trust has helped make all of these possible. I do have objectives. I'm not going to bother you with those, but I'm going to start out by saying talking about death and dying is still a tremendous taboo. In our society. I found that when I started talking about all of these issues, I find that people just did not talk about it. You can see this in just some of the ways that we refer to people dying. They passed away. We lost them, you know, as a child. You think we lost them. Well, what happened to them? You know, will I get lost? They're in a better place now. My family members have actually used the term kick the bucket in the past. So, you know, sometimes it's just ways for us to cope with the actual concept of death and dying. And yet I think that not being able to say these things out loud and address them are part of the reasons that we're not facing these issues today. And so I hope that we can get better at talking about things like death and dying. So overall, as I said, I found that I couldn't just jump right into the conversation project tools without kind of setting the scene of what we're talking about here. And so what is advanced care planning? And that is making decisions about the care you would want to receive if you become unable to speak for yourself. And this is the scenario we're talking about. If you cannot make your own decisions, what type of care would you like? And these should be based on your own personal values, preferences, and then this is a key part, and discussions with your loved ones, because this is a hard thing to figure out. We don't know what scenario is going to face us overall in the long run. And so starting to explore our own thoughts and wishes, figuring out what we think about things, and then really having good discussions with everyone possible, our loved ones, our healthcare providers, our healthcare proxy in particular is incredibly important. And that's because what we find is that people end up making decisions for others in times of crisis. And we know that is the worst case scenario. It's filled with stress. Most of us are not healthcare professionals. And even if we are, we don't know what these scenarios are sometimes. And so knowing what decisions should be made based on a person's own wishes really helps alleviate stress and guide us, if possible, to have these laid out ahead of time. So really quickly, I'm not going into these in detail, but advanced planning documents are legal documents. They are include both appointing a durable power of attorney for healthcare, also known as a healthcare proxy, and includes a living will, which only goes into effect when one is terminally ill or in a permanent unconscious state. So it's a narrow window of when these actually go into effect. And then they address all of these different types of scenarios. And again, this is going to be what Monica is going to go over in more detail. This is not what I'm going over, but again, I have this image of this kind of compass because what we find again is that we don't know what exact scenario we're going to face. And so these documents and these discussions help act as a guideline, help guide us in those moments when we really do have to make those decisions. Some things to consider, goals change over time. Sometimes we feel like I'm well, I can fill this out, knowing that it's possible that my event, things can change. I can be diagnosed with an illness that becomes a serious illness. I can become terminally ill. I can have a crisis scenario. So we have to make sure that we revisit all of these over time. And every time we revisit them, as far as the documentation, we also have to revisit those discussions with our loved ones or others helping to make those decisions. If you have not read Being Mortal by Atul Gawande, I recommend it. It's really an important book that talks about how, modern medicine has gotten really good at saving us. And yet sometimes those scenarios where our bodies go on living are not ones that we would choose to have. The choice of quantity over quality becomes a big issue. And a lot of times that's not discussed. And so Atul Gawande, in talking about all of this with his book, has really opened up a lot of good discussions. A little bit about what we know. Kaiser Family Foundation has done some good studies. And we know that people, according to this last survey, people want to talk about their end-of-life wishes some with their doctors, a lot with their spouses, some with their children, some with parents, and some with spiritual advisors. Sorry, I'm going to let someone else in. So people want to have these discussions, do they always? Another study by Kaiser showed that people want to have a say in their medical decisions, and they really want their doctors to be honest with them. Only 7% emphasized the concept of hope as being the most important versus just a complete honesty in what their diagnosis and prognosis was. About half the patients believe they have too little control over their medical decisions. So the dark blue is the too little. So overall, the survey respondents said that 49% thought that they had too little control over their healthcare decisions. And I thought it was very interesting that when we're in good health, we think that a little, we think that we've got a little more, but then as our health care becomes more poor or we're in decline, we think that we have too little decision-making capability. So why is that? I think things get stressful and things get, we're focusing on the next plan and the next treatment and the next appointment. And so those bigger decisions kind of go away a little bit. So 1 in 10 report, this is back in 2016. I would actually be curious for them to redo this after COVID. But at that time, 1 in 10 report discussing their own end of life care wishes with their healthcare provider. But I thought it was interesting. So on the left here, it says people who say they've had their conversations with their doctor, and that, can vary by age. Versus the amount of people who say that they have had a discussion with a doctor about somebody else. Somehow that seems to be a little more possible sometimes rather than discussing our own issues. And, lots of people say that they want to have their end of life wishes written down, but a lot of people have not. So my friend Molly, who's on the call, always says, people take more time and make more effort in researching the next car they're going to buy, as opposed to actually researching what types of decisions they want to have made and then making sure that they're documented. So exploring, how do we get going on this and why is it important? Exploring our own goals, our values, and our wishes. What type of person are we, and how does that influence the type of care that we want? Remember, making no decision is a type of decision. So there are lots and lots of people out there who just will never make this decision. They will assume that the right thing is going to be done, but it doesn't necessarily reflect their own goals. And I find that there's a lot of assumptions that we make about decisions. So we assume our loved ones know what kind of care we would like if they have to make a decision for us. And I can tell you, unless you actually talk about this with your loved ones, you will find that they don't know what your decisions are. We are all unique people and have unique experiences that we bring to the table. And so unless we voice these, our loved ones won't necessarily know. Two is our loved ones will make decisions for us based on our wishes, my own wishes, rather than on their own. Again, if they have no way to separate what are their wishes versus what are our wishes, they probably, it's going to be harder for them to make a decision based on ours versus their own. This is a big one that we see all the time in healthcare. Our loved ones will come together and agree upon the type of care that we should receive based on the best information they have to guide them. I can share with you that in the medical community, this is one of the most challenging scenarios, is that people's loved ones, family members or loved ones are fighting, they don't agree. They may have one scenario in place where they think things are going well, and then somebody from out of town comes in and disagrees and changes everything. So it's really important that we start having these conversations early and often. If we identify somebody who really is just not going to go along with our wishes, figure out how to deal with that and figure out how to empower the rest of the group or your healthcare proxy, hopefully, who you designate to deal with that. We also assume that our doctors will tell us when they think we could die within 6 months or a year, and will help guide us based on that knowledge. And I can tell you that it's tough for doctors. I just saw a report, I was just at a conference, and they shared that, in fact, doctors who have had a long established relationship with their patient tend to vastly overestimate the amount of time they have left to live. And they think that there's just this sense of, optimism. They want them to be doing well. And so we have to be ready to start these conversations, not only with our loved ones, but with our healthcare providers as well. And then we'll get to this more, but sometimes the best person to make a decision is not a family member or a loved one. So we'll get into that a little more. Jessica Zitter is a physician who's really started talking a lot about types of decisions that need to be made and how to make them. And she just posted this on why do doctors shy away from the dying process? And, you know, I'm not pointing any fingers. A lot of times they really just don't have training in this. But I thought these were some excellent points: lack of communication, training or skill, fear of patients' emotions, fear of being wrong about the prognosticating how long the person will have, just a lack of time, you know, how their days go, feelings of personal failure, fear of being labeled a failure by others. I've heard, you know, physicians don't like the thought that their patient is going to fire them if they, you know, are honest with their diagnosis and prognosis. So again, you know, if you are the type of person who really wants all this information, then you may have to be willing to guide this conversation. So there are other tools. I had mentioned that we're going to talk about use the Conversation Project. And there are others. I've even heard recently that on the University Hospital's website for their advanced directives, they've got a nice toolkit there with some good questions. So there's also something called the End of Life Deck. It's kind of a card game. You could sit around, you know, in a setting with your loved ones and kind of pull a card and just discuss it. The Go Wish game is online and really is sort of aimed at more really terminally ill people. Jessica Zitter, the same doctor I was just talking about, actually put out this short film, 24 minutes. And it's really set in an ICU and goes over people who are facing real very difficult decisions, and it can really help shine light on some of those scenarios, and that is available on Netflix. So we use the Conversation Project because it's just very well thought out. Again, every tool brings some different scenarios to it, but it was started by the Pulitzer Prize winning author Ellen Goodman. And I wonder if we could jump right in, and I wonder if you all would be willing. I'd still love to see your faces if you're willing to show me, use your video. And, you know, if you want to unmute and ask a question, you can. Molly, I'm going to ask, I see you're on there, if you could help, you know, if anybody has a raised hand or a chat point or anything like that, then if you could help me administer that. Sure. But so we need to start with just exploring our own wishes. And some of the things that it's helpful to do are say things like, you know, if you're getting toward the end of your life, what does a good day look like for you? And I say getting toward the end of your life because, you know, a good day for me today may look vastly different than it does if I'm very seriously ill. So again, it's, you know, what is my thoughts on a good day? I mean, I can tell you a good day now would probably be, you know, a beautiful book reading, or a beautiful day and sitting out on the patio reading a beautiful book and having somebody else cook for me. So, but you know, things change over time. We know things, just your goals and your values change as your healthcare changes. Who or what supports you during difficult times? You know, are your faith leaders someone who really are important in your life? Who knows that? Do your loved ones know how important that person is in your life? Do you share everything with your best friend, or do you really prefer to be very private? What matters most to me through the end of my life? So, you know, this gets to some of your goals: being able to recognize my children, being independent. What's really important to you? And some of these things also come down to goals as far as timing. You know, we've all heard the stories of someone who just wants to walk their daughter down the aisle, or son down the aisle when they get married, or, you know, go to a life event, a graduation or an anniversary or something like that. So if we can start really thinking about those things for ourselves, I am personally not really fantastic at planning ahead. So would a time event be important to me as much as just really living my days well? I don't know. People process information differently. So, whoops, oh, I'm sorry about that. So, I have a friend who has a PhD and, is amazing at researching everything. And yet she knows that if she gets serious news, she does not want to be the one to get it. She cannot process it in that moment. She wants her spouse to be told that big news so that they can go home then and process that together, and she can, get the information she needs in the time that she needs it. I am almost the exact opposite. I want every bit of information possible, but I do know that I'm also not fabulous at making hard decisions in the moment. So knowing that, if I were to appoint a healthcare proxy, probably one thing I would look for is somebody who's really good at thinking on their feet and evaluating things in the moment, as well as being a bulldog and really working toward whatever goals, I've laid out. So this is an important one. How long do you want to receive medical care? Indefinitely, no matter how uncomfortable the treatments are. I recently heard of a woman about my age in their mid-50s who had cancer, and she was clear. She had, kids who were in their late teens, early 20s. She wanted every form of care treatment possible. She was adamant that was what she wanted. And so that's what she did. She pursued every single treatment, and it was tough. And it did not end up curing her. But she felt that it was important to be seeking that treatment until her last days. There are certainly people who have had treatment over time, and they have found that, I don't want another form of treatment. I've had surgeries, I've had, a series of things. And what I think is more important is my quality of life. I want to spend my time in the way I choose. And maybe treatment is not part of that choice. But until,
no, sorry, go ahead. I was just wondering if anybody wanted to offer their, looking at these questions, does anybody have any thoughts or anything? I'm sitting here, the first one really always resonates with me. My sister is visiting me right now, or not, no, not the first one. My healthcare proxy thing is really important. My husband is a lovely, lovely man, super duper sweet, but he also does not make decisions in a timely manner all the time. And I'm always concerned he's going to hesitate, or he's not going to honor because he's going to think this or he's going to think that. So we've kind of made an agreement between my husband and my sister that they will duke that out in the hospital, but they'll both listen to each other because she knows what I want. And she just has the type of personality that is going to be a little bit more of a bulldog than my husband, who's just a little bit more than, laid back. Tom?
I actually dealt with this for 20 years with my mom, and she was suffering from dementia the last 9 years in a nursing home. If I had known about VSED, she would not have suffered near as long, but didn't. But what I did do is, when she still had her cognitive ability, I sat down with her one day, got down in front of her on my knees, held her hands, and talked to her for almost an hour about what her wishes were, what her desires were, what she wanted me to do, because she knew what was going to happen. And I did not realize it to the degree that it happened. but it provided the most peace for me through the entire process for the next 20 years of what I went through with her. And so I'm in my mid 70s and I had done that with my kids. And I have made it very clear what my wishes are. I have multiple written directives. I have just changed doctors because they could not agree to follow my written directives. And so it is a very challenging process, but to the point exactly of what we're talking about, I will not go down the path my mom went down. And my partner, who I've been with for 17 years, she will not go down that path. Quality of life is much more important than quantity of life, but you have to be engaged in the process and you have to be very proactive and planning ahead.
And Tom, what you just said there resonated. We did the same thing with my sister-in-law, who also was living with Alzheimer's. And we had those conversations. And because we had those conversations, we were so much, it was so much easier to be present with her because we weren't having to guess about everything all the way along the way.
Yeah.
We'd have those conversations. Same thing with my parents. So when the time comes, I do think it gives people, it's a gift. And you give them the opportunity to be present with the person instead of having to worry about, second guessing themselves all the time.
Yeah. And the thing you said, Lisa, about being decisive, my partner is a toxicologist. So, we have very in-depth discussions and you have to be decisive so that people around you, whether it is your family, whoever your POA is, your doctor or the medical facility, because there are so many parameters now and there's so many things that can override your personal wishes. It's a real challenge to be sure that is adhered to when you get to that point.
And I think that sometimes, as we're going through, we're just starting now talking, we're just starting with this conversation project, starting about, to explore our own wishes. And sometimes having these conversations with others, our loved ones and our doctors and things like that can be difficult. So that's one of the reasons these tools are helpful. But I have found that conversations can start in sort of surprising ways. One of my favorite memories of my own grandmother was we started out talking about funeral planning. And I was very nervous about it. Her funds were in short supply, and we had made the decision that probably pre-planning her funeral would be a good decision for her. And whereas I was very nervous about broaching the subject, she jumped right into it. She had seen a lot of that over her life, and she started talking about the different caskets she had chosen and Uncle Charlie and this person and that person. And it really led to a lovely discussion of her thoughts, but a bigger, more rounded discussion on, Grandma, what type of care would you like? And so it was sort of an unexpected in to this type of conversation that sometimes can be hard to broach with people. So this leads us beautifully into this whole conversation about how to choose a healthcare proxy, and Conversation put out this great video. So this is about 2 minutes. So bear with us.
Healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know best, right? Be your healthcare proxy? Sure, I'd be happy to. If I'm in town, check out my Instagram pics from Peru. Wish you were here.
Oh, I could never let you go. I can't even throw a plant away. As long as it's got one little green leaf. I'd be like, can't we upload her to the cloud?
Well, heck yeah. I've given this a lot of thought. Let me tell you what decisions you're best off going with. You never let them resuscitate you. And if they even try to hook you up to one of those breathing machines, never. I got this. I totally got this.
How can you even talk about this? I can't, okay? I just can't. Mom, it's not like you're gonna die. No, I can't talk right now.
Oh wait, did I show you that meme from iFunny? The cat and the dishwasher?
Well, hon, you and I have been through so much together. Here's what we'll do. We'll sit down, we'll get a cup of coffee, and you tell me what matters to you.
Well, it wouldn't be easy. I mean, I'd be sad, but I'd have your back.
I remember when we went through this with Mom, we really spoke for her. So I think I can do that for you. Let's talk about what you would want.
That is, oops, hold on. Now I have to figure out where to advance my slide. There we go. I thought it would be interesting to just go over a couple of quick health case studies because healthcare proxies can kind of be called in for different scenarios. And so I wanted to share this case, Ellen F., who at the time was a 78-year-old woman with no serious illnesses with decision-making capacity. She had recently moved into an independent apartment on a continuum of care campus. She had appointed a healthcare proxy, and part of the reason for that was because her own son did not feel comfortable making decisions for her. So she had a healthcare proxy. And that person received a call from the emergency department saying that Ellen had fallen, had broken her leg, required surgery, and she was really in and out of consciousness, and they didn't feel that she could make her own decision. And since she had a healthcare proxy, they talked about it with them. So this is a fairly, I don't know, straightforward decision. You know, it's surgery. It's kind of a one-time scenario. So the surgery was successful. Ellen did suffer a little bit of delirium, which can happen at times with anesthesia for a few days, but she did improve. She went back to her apartment. Her leg did largely heal. And then after that, Ellen started over time demonstrating some mental decline. So this is kind of just a scenario where the proxy is just kind of making a one-time decision, short-term thing. It was a somewhat straightforward decision. The next one is actually Ellen about 10 years later. And over time, she had had more of a history with falls. We know that one of the biggest risks for falls is falling is a history of falling. Unfortunately, she had a lot of broken bones. She had had dementia that progressed, although she had moments of lucidity in there. She had moved to a nursing floor within the campus. She did need nursing care. And that time, the healthcare proxy received a call from the emergency department saying she had fallen. She had really taken a bad fall. She had hit her head on the sink. Of course, there was blood, but she had lost consciousness. And they really had difficult decisions to be made. So that took more of a conversation with the doctor. You know, what was her current status? What was their assessment to the best of their ability? Should tests be done to figure out the extent of her injuries? And should she have surgery if that was, they thought it was needed? They really had a full discussion about this, and the healthcare proxy, based on all of that scenario, decided that she asked the physician, do you think that this is an appropriate time for Ellen to go into hospice care? And the physician said, absolutely. And so then had the social worker get involved. They found an inpatient hospice facility, and Ellen was transferred there. She never regained consciousness, and she died 3 days later. So those decisions were based on conversations that they were able to have over the years between that first surgery scenario and all of these things that had happened over the years. And that, you know, this is a difference when the healthcare proxy really did have to step in to make this very difficult decision. But they had talked, and Ellen was really clear that she didn't want to go to the hospital. She did not want testing. She didn't want a lot of intervention. She was ready to go meet the Lord. She, read her Bible daily, and she knew her time was coming to an end. So based on all of those things and her, healthcare scenario, the decision was made for her to go into hospice, and Ellen did die. Does anybody have any thoughts about that scenario?
I have a comment to make. The thing that is important, and you have laid it out, but I want to reemphasize, my kids understand my desires and wishes. It's very clear they don't agree with them. And they are not my primary healthcare POA. If it comes down to them, though, what I have asked, and we pretty well talk about things without a filter. At this kind of the way my family is. And I said, I don't ask you to agree with me. I just ask you to do follow what my wishes are. And if you can't, that's okay. But I want to know now and not when the situation presents itself. And I think at least for me, that gives me the peace of mind to know that they will do that if in fact it comes to that. But I'm extremely sensitive to the quality of life, and I'm kind of where Ellen at 88 was, not where Ellen at 78 was, but it does progress. But that understanding, I think having that, it has to be totally transparent from both sides for it to work.
And I will say, a little more information about this. Most of her family was in agreement about this, but she had one son who came in and said, Mom, I can't let you go. It's not time yet. And, if he had been the decision maker, this whole scenario could have played differently. So we also have the task of preparing to talk with our doctor. Now, the interesting thing about saying this alone is that there's this whole, healthcare today is so complicated. We have hopefully our primary care physician, maybe some specialists. Hopefully we have a relationship with people that we can talk to and discuss all of this with, who may or may not want to have these discussions. There are times when I have heard of people who said, hey doc, let's talk about this. And they say, you're not going to die. You've got years ahead of you. We don't need to talk about that. And versus a doctor who says, you're right, let's talk about it. I want to know. So there's that scenario. Say you go in, you have your primary care physician, you actually know them, you have a relationship with them, you document this, you have a great discussion, you plan ahead for this visit. And then an emergency happens and you're hospitalized. Who is in charge of your care? But a hospitalist usually these days. They may or may not have a discussion with this primary care physician who has known you for hopefully, these days it's hard to have a long-term relationship with those people. So it's really important to understand where you may be getting care in what scenarios. And, a hospitalist has a skill set that works in a hospital, and those people are trained to save you. I'm not knocking them. I would want to be saved now for many reasons. But that's when it's important to not only have a healthcare proxy who can really ask good questions in the moment, but also bring in other tools. And this is where I get on my nursing hat and say, please consider asking about palliative care. If you had not heard about that, that's care that's given specifically for symptom management for serious illness care. And it's a team approach, so they can manage your symptoms, but they also usually have a social worker and a chaplain and all kinds of different people on their team that can really give you the best care in the moment. And so bringing tools to the table in these moments, where again, you've had this great conversation, and your documents are uploaded into every setting they needed to be uploaded, and yet there's still information to be gathered and decisions to be made. So I don't want you to be surprised if, hey, I've gone through these steps, I've done all this stuff, and yet here I am in the emergency department, and it's a totally different ballgame. Does anybody have anything to share about that type of scenario?
At least I was going to pop something up here too, because and maybe Monica may talk about this next week a little bit, is the option also for videotaping what you want your wishes to be.
Absolutely.
And having that healthcare team be able to hear directly from you in your own voice and seeing your face. Especially like Lisa referenced the hospitalists. These people may have never seen you before, but if your family can come in and they have you on videotape talking about your advance, directives and what your wishes are, that can really carry some weight. So I'm going to type something up here. It's called the Mideo card, and it's actually a video. It's like a formalized video advance directive. And we'll provide some more of these opportunities. Monica will probably be giving me some materials to send out to you this week. But video advanced directives, videotaping them can really be a good way to communicate and just kind of support your written documentation.
And please remember to use your tools. You've got phones. You can record conversations so that you remember these things later. Let the doctor know that you're recording it, but they usually are, have no problem, because they understand that in that moment of getting bad news, what we hear is, we turn into the Charlie Brown voice. Wah, 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 wah. We cannot process a lot of this information in the moment. And so using, having someone with you that you trust, but also using your tools, just recording that conversation can really be a tremendous help to revisit and understand things later. So those are some of the things that Molly will be talking about at the last one in our series. And a lot of people, we have what time is it? We have a little bit of time. One thing that we didn't go into so much this time is the discussion of dementia directives, advanced directives that address issues for people who are concerned with dementia and Alzheimer's. So if you go to our website, ohiooptions.org, check on the resources tab, we've got a link. New York State has a nice dementia directive, and that's talking about the type of care you would want, again, if you are concerned about living with Alzheimer's and dementia. The challenge with that is that those are not a lot of times legally enforceable so far. There just have not been a lot of scenarios where they've worked with those and anyone's challenged the care that they've been given. But it's important to, if you're concerned about that, to start looking over that type of paperwork, again, just to start becoming familiar with the types of decisions that you can be laying out for your loved ones, for your care moving forward. It's all so challenging. The Conversation Project, again, I thought was interesting, has this guide for clinicians and the different scenarios of, are you talking with your patient who has no serious illness versus someone with a serious illness versus someone, who's got an advanced illness. And there are actually billing codes that they can be using for this conversation. Medicare actually reimburses for serious illness conversations now. So if nothing else, I would print this and bring it into them so that they have information on, you know, that you're just not using their time in a way that they are not comfortable with, but that it's okay to have these conversations. Is there anything in the chat, Molly, that we need to address?
Nope, I think I answered it.
Sue, did you have a question? You're muted, you know?
Yeah.
Yeah.
This came up this weekend where I was talking with someone, like I've already signed about being an organ donator. And I was talking to this pediatrician about, not that that has anything to do with it, but she knew just legally with things. But she was saying that if I wanted, because I also want to have my body donated after the organs are, and I'm not sure what kind of form. And then she said that that can take like a year or so before the family would get the ashes back from that. And I hadn't explored that area that much. And I just wondered if you knew something about that.
Do you want me to take that one, Lisa? Since that's
Molly's
my
resident
ballpark.
expert.
I worked in organ and tissue recovery and donation for 10 years, so I'm very familiar with this.
Good.
We
Okay.
actually had patients who had both indicated a wish to be an organ and tissue donor and a wish to have their body donated to medical science. So what happens is there are different programs across the country where you can register. Obviously, since we have major healthcare systems here, you can do that. But just because you offer to donate your body to science doesn't mean they will accept it at that time. They're going to look at what happened, you know, how you died, what happened, how old you are, what they're in need of for their anatomical programs and things like that. So usually we tell people to sign up for both. So the organ donation piece you've already gotten taken care of. So you want to look locally or wherever you want to go. You can go pretty much anywhere to donate your body to science if you're interested. Then if you were in a situation where you became potentially eligible to be an organ donor, what they would do is call the medical school where you had volunteered to be a donor. And they would say to them, okay, we have, you know, Sue here, she can be an organ donor. Here's what we're looking at. And they'll talk with your family too, to see which you want to take precedence. Sometimes the medical schools are fine because maybe certain things aren't being donated and that's really what they're interested in. But that's usually just a conversation between the organ procurement organization and the medical school. And then my brother-in-law just donated his body to science, and we got his ashes probably about 6 months after. And again, it can be up to a year because it really just depends on what they're using it for clinically. But they do obviously then, you know, will cover cremation for you, you know, get it back to your get the body, you know, get your remains back to your family.
So what would you, I guess right around Cleveland, who would I contact in terms of the body? Just my body.
So maybe we can follow up with you a little bit more on some of those details, if that's okay.
Sure.
Yeah. And then
I can find out from one of my friends at the OPO who's doing body donation right now and we can get that information.
Okay, thanks.
I believe part of those are documented in the advanced directive, though, to some degree, but finding out, you know, the details, of course, Sue, is you know, important. So
yes, Monica's going to talk about organ and tissue donation next week as far as an advanced directives go, because you can also designate exactly what you want donated. You can have everything you're eligible for, or you can just say, I just want solid organ, I don't want tissue. And a lot of people don't know that they can be that specific about it. So Monica's going to talk about that next week. So one of the things that's going to really help if you're, you know, coming to the session on next week is to really look at the, look at the materials that we sent out from the conversation project in terms of this, because Monica is going to briefly go over the advanced directives for Ohio, the advanced care directives for Ohio, but she's really going to give you an opportunity to fill in some of these things. Again, we're going to send you all the links for this documentation. But you'll want to have kind of that thinking process. You've kind of got a week to kind of look at the conversation project materials, help to kind of process those. And then, you know, you'll be ready next week for Monica's session where she'll do things a little more hands-on, let you look at the forms, let you ask questions about the forms, and be able to, you know, just kind of have it be a little bit more interactive and hands-on.
Thank you, Molly. Great question, Sue. So I have to say, I have to acknowledge that I did not go in detail over the conversation project starter kits and the various types, but I think it's really important to kind of set the stage and show some scenarios to help you think about why this is so challenging and some of the things you may face, and why we want you to go through all of these with the conversation project, or whatever toolkit you end up finding is good for you. And just how to be as complete as possible, and emphasizing that the conversation is king. I mean, it's just or queen, or however we want to say it. It's just so important to continue with these, you know, really talking to people in addition to documenting things. Does anybody have any questions? All right, well, thank you for joining us. Please feel free to give us feedback or let us know if you have questions leading up to the next session. And please do plan on joining us for the next 2 sessions. I think they're really going to be useful. You can also invite friends if you think that they would like to join you. So anything else we can do? Otherwise, thank you for joining us and have a great night.
Thank
See you
you.
all next week. Bye-bye.
Thank you.
Hi.
You're welcome.